Discuss Ebstein anomaly today. Ebstein anomaly, I'll take care from the pathology, the anatomy, and the hemodynamic effects of the Ebstein anomaly. It's not very common anomaly, but it's about 1% of the all congenital heart disease patients born. But we have now and then see the patient of Ebstein anomaly in a prenatal period. So I'll discuss the details of how to recognize Ebstein anomaly in the fetus and how to understand the hemodynamics to make an assessment whether this patient would have an impact in the prenatal period or in the transition period. So let's get going here. My talk is going to be in this format. I would discuss about anatomical components of this and then immediately followed by what are the echocardiographic parameters in fetal echo when we do it, and how do we differentiate the common conditions which can mimic Ebstein's anomaly. And then we would certainly like to share with you what are the associations, genetic associations, the other cardiac defect associations, or extracardiac associations with Ebstein anomaly. All that boils down to what are we going to discuss with the parents and how are we going to counsel. The counseling involves three major components of discussion. The first and foremost discussion is that is this compatible prenatal period? Is the incidence of prenatal mortality high? Is the fetal demise likely? So that's very first question which parents would wish to know. Second one, where should we get the surgery done? Should it be in a tertiary care unit? So that's we want to know what happens in the transition period. Thirdly, they would like to know what is the surgery, how many surgery would be required, what is the success rate of the surgery, and what obviously is the cost of the surgery. In our part of the world is borne by the patients themselves. Then we would certainly discuss cardiac arrhythmia, their management, pretty common in patients with the Ebstein anomaly. So let's discuss the anatomical components. William Ebstein was the first person to describe in late 90s about Ebstein anomaly, and his paper was published, and it did show the septal leaflet tether. That was the first description of Ebstein anomaly, and that's where the name of Ebstein comes tagged with this disorder of tricuspid leaflets. Before we jump onto the Ebstein anomaly and tell you about the disorders of Ebstein, let's first understand the grading of tricuspid. This is how you're going to describe. Is the tricuspid regurgitation mild, moderate, or severe? And what are the parameters? We take a right atrial area and a jet area. Is a jet area divided by the right atrial area. In the percentage, we would describe tricuspid regurgitation. The first case the video clip shows, it's a mild tricuspid regurgitation, but the area filled by the TR jet is less than 25% of the right atrial area. The moderate one is between 25 to 50 of the area filled in the right atrium. But if tricuspid regurgitation jet fills more than 50% area of the right atrial volume, then it is called a severe tricuspid regurgitation. With this understanding and basics, let's move on to Ebstein anomaly. Now, we must differentiate and what are the causes of severe tricuspid regurgitation, and they would come back again in the differential diagnosis slide. The common are dysplastic tricuspid valve, we have an Ebstein anomaly, we have a patients with AVSD which commonly have a mild tricuspid regurgitation, but rarely they can have a severe TR. Then there are kind of very uncommon disorders, which certainly I'll show you, unguarded tricuspid orifice, and I will discuss with you the papillary muscle rupture, and you can have a patient with the parachute tricuspid valve. Then there are secondary causes of tricuspid regurgitation where the structural abnormality is not with the tricuspid valve. It's somewhere else. Either the right ventricle is enlarged or there is a pressure overload on the right ventricle. So there are many causes because secondarily involving the tricuspid orifice and leading into tricuspid regurgitation. So let's discuss the hallmarks of tricuspid regurgitation here. The hallmark of tricuspid regurgitation in Ebstein anomaly, that's how it's pathognomic of Ebstein anomaly, is a movement of the septal and the posterior leaflet towards the apex. What does it mean? It means that normally all the leaflets are attached on the annulus. Done? Now, if the leaflet are not attached to the annulus, they are moved further down into the apex. So that causes a displacement of that leaflet. And by that displacement, the angle of the tricuspid orifice, it rotates anteriorly. And this orifice can come into the mid of the right ventricle wall chamber, or even into the right ventricle outflow tract. Now, just trying to compare the anatomy, normal one with the abnormal in Ebstein, the tricuspid valve leaflets, the septal leaflet, there are two leaflets. One is a septal leaflet which is visible on the fourth chamber. Two is this anterior leaflet on the free wall of the right ventricle. The third one is a posterior or inferior leaflet, which usually we don't see in patients with when we do a fetal echo, because small, then it's lying a little posteriorly. So now there is an offset, normal offset of septal attachment of the mitral valve and the tricuspid valve, right? We know this is the normal offset because of the crux there. And if this offset is minimized, the direction goes towards AVSD or a common AV canal defect. If this is increased, like in this patient, the septum leaflet is actually coming right attached to septum here. This is the displacement of the attachment, and then this becomes an Ebstein anomaly. Why does it happen? Now, it happens because the septal leaflet is actually tethered. It is not delaminated from the septal wall. Now, if the septum is attached, the tricuspid, the septal leaflet is tethered to the septal wall, it only gets released here, and it looks as if the attachment is somewhere in the middle of the septum, right? Now, the second main component of this is the anterior leaflet also enlarges, remodels, becomes bigger to reach close to the septal leaflet, just trying to close the opening, right? So this is a large sail-like anterior leaflet present on the free wall of the right ventricle. This also can be occasionally tethered to the right ventricle free wall. Now imagine what is happening. This is the tricuspid orifice which is moved down towards the apex. This is the orifice of the mitral valve. Now, by moving the tricuspid orifice down, what is happening here is this portion of the right ventricle is behaving like right atrium, because the orifice has moved distally. The proximal part of the right ventricle becomes what? It atrialized, it becomes kind of part of the atrium, and we have a very small residual right ventricle which is functioning and behaving like a ventricle. So now the right ventricle power has gone down. Now this is another very important aspect. The right ventricle is very small in severe cases, so small that it is unable to push the blood into the right into the pulmonary artery. It cannot generate that kind of pressure to push the blood into the pulmonary artery. So that is in large shell, the basic pathology. Apart from that, you notice there is a thinning of the right ventricle wall. This again forms a component of tricuspid abnormality in Ebstein, and this leads to area of arrhythmias. Multiple arrhythmias are known in Ebstein's anomaly. Let us see the representative cases. Before that, in this diagram, you see this, what I tried to describe you, the septal leaflet displays here. Now the entire orifice is displaced toward the apex. This is the characteristics of Ebstein anomaly, and this we are going to use in differential diagnosis of various other conditions. Now in this, what happened, the TR jet That's sometimes you may not see the displacement of the valve. I'll show you one case. But if you don't see the displacement of the valve and you see the TR jet, the PISA is originating here. The TR orifice is here close to the apex, not close to the mitral valve insertion. So if you see this is moved downwards, this also indicates the orifice has moved down, and if orifice has moved down, this is Ebstein anomaly. Okay, so that's what is the downward displacement towards the apex. Let's see the case. Now in this case, if you notice, this is the right atrium, this is the left atrium, then you have a left ventricle, and then you have a septal leaflet which actually is kind of tethered to the interventricular septum, and it opens only here, that is close to the apex of the right ventricle, and there is a large anterior leaflet. Agreed? Now making the orifice, look at the orifice of the mitral valve, look at the orifice of the tricuspid valve. Orifice of the tricuspid tricuspid valve has moved towards the apex. So there is a displacement. Now because of this displacement, there is a tricuspid regurgitation where jet you see is originating quite close to the apex and not close to the mitral valve insertion. Right? These are the telltale signs of Ebstein anomaly which should alert you. Same in the diagrammatic fashion, showing the septal leaflet moved down, the large anterior leaflet, the orifice actually moves down toward the apex. Again, let me show you another case. In this case, you see the septal leaflet which is kind of tethered to the septum. Right? There is a right atrial enlargement. The septal leaflet is tethered. We have a large anterior leaflet which is trying to compensate for that loss of the septal leaflet, and the orifice is moved down towards the apex. Then you have a large anterior leaflet, okay, and the septal leaflet, it's moved down towards the apex. The opening is moved down. So that is the important finding of Ebstein anomaly. I just try to elaborate and repeat that thing because that's what is going to be the most important aspect. How does it happen and why does it happen? Genetically, we born with two spongy ventricles, and when the spongy ventricles are compacted and there is a delamination of the valve leaflets from the ventricle. So remember, the AV valves are formed in the ventricle. They are part of the ventricle. So the right ventricle would have its own tricuspid valve. Left ventricle, if it is present on the left side or the right side, doesn't matter, but would carry its valve along because they are part of the ventricle. Embryogenesis of valve leaflets is from the ventricular wall. Occasionally, the ventricular wall is thinned out, and this thinning I described you of the right atrium also compensates, produces an abnormality in the rhythm and can lead to multiple arrhythmias. The very first classification was offered by Carpentier, and he described that we have a septal or posterior leaflet displacement little down with the muscle in the ventricle maintained in the atrialized portion, and if this atrialized portion has the muscle thinning and the leaflet is moved quite down towards the apex, this is type B Carpentier. Type C is that anterior leaflet is also tethered to the septum, and in the severe cases, only right ventricular outflow tract is the only area of a contractile right ventricle preserved. So that is why in case this is the small area, D is the severer form of Ebstein anomaly. So if this is a small area of right ventricle, it would have a difficulty in pumping the blood into the pulmonary artery. It would function like an RV dysfunction. Again, putting them in order, these are the various components of the Ebstein anomaly. We must remember that because of atrialization of a large chunk of the right ventricle, the part of the right ventricle loses its part to become the right atrium because the valve leaflet apex is moved down. So the right ventricle sacrifices large portion into the right atrium. Now, the residual right ventricle in sphere form is not enough to generate pressure into the pulmonary artery. This can lead to pulmonary atresia. This can lead to a functional pulmonary atresia. We'll try to dissect these two things. Then cardiomegaly and the right atrial enlargement leads to pulmonary hypoplasia, which again is a very bad prognostic sign. Then there are the areas of arrhythmia. Right ventricle, right atrium is enlarged, which is arrhythmogenic. Right atrial wall is thinned out, it's arrhythmogenic. Then there is a necessary pathway which can produce a WPW syndrome, that is White Parkinson syndrome. Just to begin with, one case is an Ebstein anomaly, can be picked up even in early gestation, and this is where you see the Ebstein anomaly in the first trimester. You don't see a septal leaflet well, but you do see a large anterior leaflet, and what you see here is that you see the severe tricuspid regurgitation originating right absolutely close to the right ventricular apex. And this torrential tricuspid regurgitation has a jet velocity of about 180 centimeters per second. This was an Ebstein anomaly. In the differential diagnosis, I told you tricuspid dysplasia, unguarded tricuspid orifice, and ruptured papillary muscle. Let me show you the cases. Now, this is the commonest as problem which can actually become a differential diagnosis of Ebstein anomaly. So what does happen here? Now the tricuspid valve is thickened, is myxomatous, it is curled. Now these thickened leaflets are there, but it is not displaced towards the apex. That is the catch. This is the septal leaflet or any other leaflet are not tethered, that they don't move towards the apex. So the orifice remains at the place where it should be. The TR jet also remains, the orifice remains where it should be. A displacement of TR jet or a displacement of tricuspid orifice down differentiates this condition from Ebstein anomaly. Look at the tricuspid valve and fast from the ventral view on a 3D echo, and you see the thickened tricuspid 3 leaflets, and this is a characteristic of dysplastic tricuspid valve. Unguarded, absolutely uncommon. An unguarded tricuspid orifice means that the tricuspid valve is either absent or just filamentous or some small rudimentary structure. It's largely open, the orifice, you can see a largely open orifice. I don't have a fetal echo on unguarded tricuspid orifice, but I'm going to show you an adult echo so that you can actually make what actually it looks like. Look at the small filamentous structure in the tricuspid orifice, which is unguarded. There's no tricuspid valve, and there is a free flow of blood to and fro from the right atrium to the right ventricle, as it is absolutely unguarded without any valvular tissue. But in this patient where we thought it could be an unguarded tricuspid orifice, look at a small, the area of a jet, large tricuspid jet, which is originating close to the apex. Now this rules out unguarded tricuspid orifice because this is a severe tricuspid Ebstein anomaly, and the apex is shifted so down toward the apex that we were not seeing the valve leaflets. The jet coming from here rules out unguarded tricuspid orifice, and this becomes an Ebstein anomaly. Absolutely uncommon condition, parachute tricuspid valve, where all the valve, the thickened chordae are attached to the single papillary muscle, and what happens? They look like a wonderful parachute opening in the diastole. You can see that with a green arrow. Then there is a regurgitation, could be a stenosis, but this all happens because of the single papillary muscle where all these chordae are attached. The hallmark again is no displacement of valve leaflets and no displacement of tricuspid regurgitation orifice. The ruptured papillary muscle can happen because of severe RV overload. and once it ruptures, the head of the papillary muscle can prolapse to and fro into the right atrium and the right ventricle, and you have a severe tricuspid regurgitation. Characteristic, again, hallmark, that the apex of the orifice of the tricuspid valve is not shifted towards the apex. The TR jet is not shifted towards the apex, so which is characteristic Ebstein anomaly. Now, guys, I know that you would have understood how to make a diagnosis of tricuspid abnormality of Ebstein anomaly. Again, I repeat, the hallmarks are downward or apical displacement of the valve orifice and apical displacement of the regurgitation orifice. Let's see the case. This is the patient where the severe tricuspid Ebstein anomaly. You see the tethered septal leaflet, and it is not opened till here close to the apex, and you see some redundant tissue of the tricuspid septal leaflet which is prolapsing into the right atrium. Now you see there the jet of the tricuspid regurgitation is originating just close to the RV apex, right? So that means this is an Ebstein anomaly where the valve orifice has opened, has moved towards the apex. Now look at the small right ventricle residual, which now poor fellow is going to be pumping into the pulmonary artery. And because it cannot actually produce that kind of pressure, the pulmonary arteries are small, they can become hypoplastic over a period of time. The small pulmonary artery, fortunately, the RV is able to generate enough pressure to put blood into the pulmonary artery. You see the antegrade flow, correct? Many a times it is unable to do that, and there is no flow across the pulmonary valve. So in this video, you see even on the parasternal long axis, you see a tricuspid orifice because it has moved toward the apex. And look at the TR jet, which is emerging right close to the apex. And if you see the tricuspid regurgitation, it is less than 2 meters per second or less than 200 centimeters per second. That's important because why it is important? Tricuspid regurgitation velocity tells you the strength of the right ventricle. I'll share with you in subsequent. Now look at this. Now you see this is the sagittal view, and what you see here is that there's a retrograde flow in the ductus, done, but there is some forward flow marked by arrows across the pulmonary valve. So pulmonary artery is now being filled both retrogradely by the ductus and prospectively through an antegrade flow across the pulmonary valve. Both these have a very important implication on pathology and on the severity and prognosis of Ebstein anomaly. In the lower panel on a pulse Doppler, you see both reverse flow and forward flow. Now this, if I describe this case, I would have described and put in my report that this is a severe Ebstein anomaly. It could be Carpentier C or D or 3 or 4. Then there is a reduced pulmonary flow. There is a forward flow, but it's reduced. But the ductal flow is reversed, that we saw that. So Goose score is 1.07. What is that? Subsequent slide, I will show you. Trip score is +4. What is that? I will show you. Before that, I must, wind up the anatomical and other associations with the Ebstein anomaly. Genetically, if you have a syndromic Ebstein anomaly, there are other associated extracardiac abnormalities. Chances that 11% of them would have some genetic or a chromosomal abnormality, and they are likely to be more common in patients those who used benzodiazepines, varnishing agents, or exposed to lithium. Lithium, we always thought very heavily on lithium, that is very high risk, but now it's not as unsafe as we previously thought. I'm going to show you a very good association with Ebstein anomaly, and an Ebstein anomaly with non-compaction of left ventricle and right ventricle. In this case, you see, let me describe the anatomy here, the first video. Now the video you see, there is a pericardial effusion, the both ventricles are not contracting well. So there is a ventricular dysfunction, there is a large pericardial effusion, indicating what? Hydrops. Yes, so that means we are dealing with a bad situation. Now, if you notice, the tricuspid, the leaflet is moved towards the apex, which indicates what? That this is Ebstein anomaly. Done. Apart from that, at the apex, you see this trabeculated portion. You see the spongy left ventricle and right ventricle at the apex. The sponginess indicates what? It indicates that the ventricle has not compacted. So this is non-compaction of the ventricle. You can see the blood filling in those recesses of the sponging myocardium at the apex, and this is Ebstein anomaly, which has a very good common association with non-compaction. And if I tell you the association, there are case reports where you have in the myosin heavy chain 7 mutations, actually very common in patients those who have Ebstein plus non-compaction, and we believe it is non-compaction of the leaflets as well as non-compaction of the ventricles, which probably have the same evolution in the embryogenesis. Now, what are the cardiac associations? Commonly associated with the AST, with the VST, with the pulmonary atresia, pulmonary stenosis, and left-sided abnormalities. CCTGA, again, the valve which is on the left side, which is the tricuspid valve in CCTGA, could be moved towards the apex, displaced, but it's not a true Ebstein. That's why sometimes we call it an Ebsteinoid abnormality. Now, there could be association of a VST. The VST can open into the ventricular portion of the right ventricle, or it could open into the atrialized portion of the right ventricle. The hemodynamics are going to be different. It could be associated very rarely with the tricuspid stenosis. You can see increased velocity across the tricuspid orifice, and you can see tricuspid regurgitation and tricuspid stenosis on a color M mode. Now let's come down to the very main aspect, that is how to counsel these patients. Counseling is very important. What is the perinatal outcome? One. What is the outcome in the transition period? And what is the surgery? So we'll discuss in 3 headings. Before that, we need to have great knowledge about this disease and the prognosis. Only then we can share that information with the patients, right? Okay. It's a very high perinatal mortality. That's what you're going to caution your patients, parents, that it's high perinatal mortality, about 40 to 50%. And we have devised a couple of scoring system. None is foolproof, but they are good actually, to tell us the prognosis. The very first one was described by, this is called a Goose score. And here you have you see the shaded portion. This is right atrium and atrialized right ventricle. That means the entire thing is functioning like a right atrium only. So right atrium plus atrialized right ventricular area divided by rest of the world, rest of the heart. What is rest of the heart? RV area, LV area, L area. So if you divide this right atrial area by other area of the heart, this gives you a score. Less than 0.5 is pretty good, and it's a very good outcome, and more than 1.5 is a really gloomy prenatal outcome. We were not satisfied with this because the taking an assessment of this was very difficult, and it was not accurate. We always overestimated the Goose score. We added, other hemodynamic parameters which were very important, which we ignored in the Goose score. What were those important? CT ratio. We were interested in pulmonary hypoplasia, 1P. Yes, we still are because of the cardiomegaly. That's a very important prognostic marker. Then this Salamager is the Goose score. The pulmonary valve flow, whether it's forward, reduced, or absent, that has a very great bearing. That tells us how strong the right ventricle And then we wanted to look at the ductal flow, the right ventricle, left ventricular ratios. So this is an SAS score. This came somewhere in between. This is hemodynamic plus. Then suddenly realized that, it's not important to look at the anatomical details so much. If we have a hemodynamic information, which is easy to get for almost everybody, then it will be as good or maybe better than the anatomical score. So we sacrificed anatomical components, and now we use what? There are 4 parameters what we use. TR maximum velocity. What TR tells you? Strength of the right ventricle. LV tie index tells you how bad is the left ventricle. Now the PA forward flow again tells you the strength of the right ventricle. And ductal flow reversal again tells you the quantum of blood which is going forward from the pulmonary valve, and what is the blood required from the ductus to come back to fill the pulmonary artery. So TRIP score, they actually in the study in 2020 showed that TR maximum velocity and tie index were very, very important components of prognosis, and then they added that, and that's how this score came. More than 5 is actually bad and a bad perinatal outcome, but less than 5 is okay. Let's dissect each component. TR velocity. TR velocity tells you that what is the residual RV and how strong is it. If RV is strong, only then it can actually generate the pressure, and that pressure is TR velocity. That pressure is the forward flow into the pulmonary artery. So if it is less than 2.5, it's given 2 scores, 2 points. Now, I index, in case it's bad, less than 6, which usually the case, is 0 score. More than 8 is given 2 score. Pulmonary artery forward flow. Now this is the TR jet. This is Ebstein anomaly. Look at the LV, small LV inflow, and you look at the VSD here on the 3-dimensional, and you see the tricuspid regurgitation coming close to the apex. And then what you notice here is this is a bidirectional flow, but there is a forward flow in the pulmonary artery. So ductal flow is bidirectional, like I showed you in the previous case. Bidirectional is given score 1, and if it is purely retrograde, it's given score 2. So based on these scores, you make an assessment whether it's +5 or -5. We are learning more. After 2020, we learned another aspect of wasteful circle or circular motion. Now, what is wasteful circle? This is another important parameter of morbidity and mortality in antenatal period. Just give me attention. You have a severe tricuspid regurgitation in Ebstein, and you have a very small residual right ventricle. Done. This right ventricle is unable to push the blood into the pulmonary artery. It cannot generate that systolic pressure. Instead, the pulmonary artery is being fed by the ductus, and pulmonary artery has a pressure that of the ductus and that of the aorta, because they are all connected with each other. So if the aortic pressure is higher than the right ventricle pressure, the PA pressure would be higher than the right ventricle pressure, and you would have a pulmonary regurgitation. Watch carefully on this. The pulmonary regurgitation, written as a PR, is continuous. It's not happening only in diastole. It is systolic as well as diastolic regurgitation. All right? That's a very difficult statement to make. Systolic regurgitation of the pulmonary valve. Yes. Now, this is the proof that you have the pulmonary regurgitation. You do a Doppler, and you see here the systolic backward flow, systolic regurgitation. Obviously, diastolic regurgitation is far stronger. In the lower panel, you can actually see on an M mode the continuous regurgitation, all the phases of systole and diastole. And the reason is the right ventricle pressure should be more than the aortic pressure, because aortic pressure is same as that of pulmonary PA pressure because of the ductus. So if the RV pressure is lower than the aortic pressure, you would end up having pulmonary regurgitation if valve is abnormal. Then what are we discussing this so eagerly on pulmonary regurgitation? It's very important. Let us say we have a right ventricle which is weak. It is supposed to push the blood forward into the pulmonary artery. That's what the job of right ventricle is, but it's unable to do it. Instead, it is pushing the blood back into the right atrium through a severe tricuspid regurgitation, Ebstein anomaly, or dysplastic tricuspid valve, or any other condition with a severe tricuspid regurgitation. Now this blood coming back actually goes through the left atrium, through the PFO and to the ventricle, from the ventricle into the ascending aorta. Done. From the ascending aorta, because the PA pressures are lower than the aortic pressure, there is a retrograde flow and the blood comes back through regurgitation into the right ventricle. Starts from the right ventricle, ends in the right ventricle, does not contribute anything to the circulation at all. This is wasteful circulation, right? So not only that, it's wasteful circulation. The next aspect is it actually entrains the other blood steals the blood from the brain, steals the blood from placenta descending aorta, to get this blood into this wasteful circle. And this is a vicious circle which actually leads to a demise. So now you see this descending aorta showing you both forward, and this is the reversed flow in the descending aorta, and that's how the reversed flow is seen in the descending aorta, which meaning that the blood is being stolen from the aorta into that circle, which is absolutely wasteful circulation. So if we do not stop, that demise is very highly likely in utero. We are trying to do something, trying to give some agents which can therapeutically produce ductal restriction. Yes, we want to create ductal restriction so that duct closes and that TR, the pulmonary regurgitation stops. In case it does stop, that circle would stop. There are a couple of anecdotal studies already done. A large meta-centric trial is underway. When we would get the results of that, and then we would recommend. Pulmonary hypoplasia is a very, very important component. Look at the thinning of the lungs. It's actually not developed on the right side. And this pulmonary hypoplasia would produce a lot of respiratory difficulties in a newborn. Now, what do you expect? How do you decide which patient actually needs a tertiary care help when the child is born? Severe cases, yes. What? Carpentier C and D, where you see the right ventricle is small. Or alternatively, you can do goose score, trip score. If the goose score is more than 5 or trip score is more than 5, both indicates high mortality, both in antenatal period and when the child is born. So all these should be actually delivered in the tertiary care hospital where immediate interventions can be done. I present you a case which was referred to us for a fetal echo, and this is that same wasteful circulation. You have a severe tricuspid regurgitation and you have a severe pulmonary regurgitation. And this was 36 weeks, and we thought the fetus is matured enough, and we took a decision of terminating the pregnancy. The obstetrician did the termination of pregnancy, and when the child was born, the saturation, it was maintaining the saturation. So we were really happy, but after 7 hours, the saturation started falling, and we had to give prostaglandins to reduce pulmonary artery pressure, for the duct to remain patent, and this was continued. And we attempted to do an angio, and you look at the angio, the angio catheter is in the pulmonary artery, and you can see there is a pulmonary regurgitation, and there was a pulmonary stenosis. We tried to open it with the the balloon pulmonary valvoplasty with a small opening. After some time, we realized because this patient had pulmonary regurgitation, we don't want to maintain the pulmonary circulation through the ductus. So we thought we'll taper off prostaglandins so that duct closes. Closure of ductus would actually stop that circle of pulmonary regurgitation. And so we stopped giving prostaglandin and we give sildenafil to reduce pulmonary artery pressure. And after some days, this is the result. We have a severe tricuspid regurgitation. We have the pulmonary stenosis and this severe pulmonary stenosis. But fortunately, there's an antegrade flow and the child was absolutely asymptomatic, not requiring any oxygen or something. Now we plan to do a surgery on this child when the child is about 4 years old. Surgery and outcome. I mean, what is the kind of surgeries we attempt in this patient? Usually in a mild cases where there's a little downward motion like Carpentier class A, or you have a patient with the Boo score of less than 0.5, then we may not actually ask the patient for a surgery, but surgery is definitely recommended. If the patient is stable, then surgery done preferably before 4 years of age, and patient is unstable, you might have to intervene right there and then. What is our approach? What do we want? The best results are two ventricle repair. Two ventricle repair, if you get this name, you must understand that we have two ventricle for two circulations. One for the systemic, one for the pulmonary. Agreed? Okay. And this is what is ideal, looking for. Many a times the other ventricle is bad, the valve is bad, we cannot achieve two ventricle circulation, we have to sacrifice one ventricle and have only single ventricle repair, and that single ventricle should be actually feeding the systemic circulation aorta. And what happens to the pulmonary circulation? We gather all SVC, IVC, put it directly without any ventricle, without any RA, without any right ventricle into the pulmonary artery. So it is less than ideal, right? You don't have a pumping chamber between the RA and pulmonary, between the IVC, SVC and the pulmonary artery. They are connected directly. Okay, there is going to be congestion. There is no ventricle there. But this is sometimes required for the survival, and this has not a very good outcome. There is something in between, that is 1.5 ventricle repair, which is that inferior vena cava is kind of allowed to go through the right ventricle to the pulmonary artery, and superior vena cava is drained into. So half of the venous circulation goes to directly the pulmonary artery, half goes through the small or dysfunctional ventricle, whatever you have it. That's the cost of surgery. I just browsing the net, and this is the site which I found, which quoted this price of Ebstein anomaly in various cities. That again, the patient is going to ask you, how much does it cost? Now, I'm going to discuss with you a cone surgery. It's called a cone surgery because it looks like a cone. This is the inferior and septal leaflet, which are actually moved down towards the apex, and we need to correct it. How do we correct it? This is the tricuspid annulus, the true one, and this is the leaflet which are moved down. Okay, now these leaflets are actually delaminated from here. They are delaminated from their insertion, right? The delamination is done, the entire, except for leaving this anterior commissure, we remove the entire valve from the ventricle wall. We delaminate it. Then we rotate it slightly and get it back to the normal tricuspid annulus. The annulus usually in this case is very large, and then we have to do some annuloplasty so that we get the valve back to the tricuspid annulus, which is a true and a very good surgery. The success rate is wonderful, about 78% surgery-free interval after 5 years of the cone surgery, which is very good surgical results. This was actually discovered developed by Jose Petros da Silva from Pittsburgh, and he achieved this cone surgery. Before surgery, this is the valve. After surgery, the valve is right where it should be, close to the mitral leaflet. Many times, yes, cone surgery is not possible. Cone surgery is biventricular surgery. It's not possible. How it is not possible? Very severe Ebstein anomaly. Most of the Ebstein anomaly, even severe, we are able to do it. But very severe Ebstein anomaly, very small RV, dysfunctional RV, or child requires an early neonatal period when all this thing is not possible. So then many times what we do is that we do a palliative surgery and plan and think if cone surgery can be done later in future. So that's going to be end of my talk, and I would end by sharing the carry home messages again, just to revise. You have a tricuspid regurgitation, mild less than 25% of the RA area, moderate 25 to 50, and more than 50 is severe. These are the causes of severe tricuspid regurgitation. And now we have tricuspid valve in this, which is moved down toward the apex and anteriorly, and there is an atrialization of the large part of the ventricle, leaving the functional or a good ventricle being very small, and it's unable to generate the adequate pressure. And you have this Carpentier classification where the severe forms are with a smaller and smaller functional right ventricle. TRIP score, which is the hemodynamic score, is based on TR velocity, that is right ventricle strength, pulmonary artery forward velocity, again right ventricle strength, the reversed flow into the ductus, and the left ventricle function, which are also important as a prognosticator. And this is the Goose score, where atrialized right ventricle against the rest of the chambers of the heart is actually indexed and given a score. This the wasteful circulation, where you have severe TR, severe pulmonary regurgitation, must intervene quickly in this kind of cases. And these are the cases where probably would require surgery, the delivery to be done in a tertiary care unit. And now we know that we can perform a biventricular repair, and that's what we call as a cone repair with an excellent surgical results in future. Thank you very much, and please keep looking for me. Please subscribe this channel so that you can keep hearing newer talks on this. And we've never actually learned everything in life. We are still learning as we go.